Yeah, so a longstanding observation is that HPV independent or not HPV associated head and neck cancer has a worse prognosis than HPV associated cancer. And although many patients are cured with surgery followed by radiation or with chemoradiation, the recurrence rates are much higher than they are for HPV initiated head and neck cancer. And so this has implications in terms of finding novel therapies, novel approaches that go beyond our traditional use of DNA damaging agents like cisplatin or radiation. The genomic character of these cancers is well known, and they are predominantly p53 mutated, and they richly express EGFR. And so historically, the targeted therapy for these cancers has been an EGFR-directed antibody, Cetuximab, but this has a relatively low response rate, and although it improves progression-free survival and overall survival, it's a relatively modest effect. There's been a lot of research over, maybe 25 years since Cetuximab was introduced in head and neck cancer, centered on patient selection for Cetuximab and resistance mechanisms. And so it appears as if, quite similar to other cancers where Cetuximab is used, like colon cancer, that if there's activation of downstream pathways, that will be associated with resistance. And although the RAS mutations that have been the predominant source of resistance in colon cancer are not common in head and neck cancer, we do see PTEN mutations or loss of PTEN expression and PIK3CA mutations, and these appear to be associated with resistance. But for many other cancers, it's not this downstream activation, it's adaptive resistance through upregulation of other receptor tyrosine kinases like MET, HER2, HER3, or activation of resistance mechanisms through the EMT pathway and through TGF-beta. And so what is very exciting in head and neck cancer, in HPV-negative head and neck cancer at the moment, is the emergence of 3 EGFR-directed bispecific antibodies, which appear to address some of these adaptive resistance mechanisms. So the first might be thought of as Petosemtamab. So this is interesting in that the second target is LGR5, a Wnt pathway component, which is largely expressed only on stem cells in head and neck cancer at baseline. And so you wouldn't think of it as a really obvious target, although those stem cells do lead to long-term resistance. But the improvement in response rate, I think our best guess is due to the fact that the early events in EGFR inhibitor resistance involve EMT and the Wnt pathway, and LGR5 is quite important there. Another one is Bintrafusp, which co-targets TGF-beta with implications, I think, not only for adaptive resistance to EGFR inhibition, but also for immune response. And then most recently, we've seen exciting data with Amivantamab, which is a EGFR bispecific for EGFR and MET. This is now available in a sub-Q formulation. Exciting data were presented at the multidisciplinary meeting in February, looking at this in combination with pembrolizumab in a phase 3 trial. And indeed, phase 3 trials are moving forward to look at each of these EGFR bispecifics added to pembrolizumab in the recurrent metastatic setting. The other characteristic that I mentioned was p53 mutation, and this has proven to be more difficult. There are agents which can stabilize mutated forms of p53, but we have a lot of p53 truncating mutations in head and neck cancer, and for these, there's not a great deal of protein to stabilize. And so my laboratory's been interested in synthetic lethal approaches for p53 mutated cancer, and I'll be discussing particularly the increased dependency on aurora kinase signaling in p53 mutated cancers. We have insights that indicate that in p53 mutated cancer, when you target aurora A kinase, there is very successful inhibition of aurora. You get disruption of spindle assembly complexes. However, it leads to cell cycle arrest. And it also turns out that it leads to amplification of replication stress. And this in turn activates a replication stress response that involves upregulation of WEE1. And we have data across both in vitro and in vivo models, including variety of genetic backgrounds and patient-derived xenografts that show that the combination of aurora and WEE1 inhibition is exceedingly active in p53 mutated head and neck cancer. So I'll be detailing some of the biomarkers that we think are going to be important for patient selection in choosing patients for combined aurora A and WEE1 inhibition, and how we might take that forward into the clinic.